This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
So I've been asked to talk, thank you very much, about alternatives to rapid response treatment or MET calls. And I guess the question is, well, why do we need an alternative method? There's been a lot of research that's gone into it. They're very well established. I guess the first problem is that they were developed to manage patients with reversible deterioration. And what we're seeing more and more in current years is that a third of people actually have irreversible deterioration. They're resource intensive, and as you saw from slides this morning, less than a third of the services are actually funded. And what we're seeing at the Austin is that we're actually having 2 MET calls at the same time, which meant that staff are being spread too thinly. And if we can reduce some of the MET calls that aren't required, then we could have more effective use of the staff that are available. Patient wishes are something that's not always taken into consideration, especially if they haven't had advanced care planning or discussions about what they want to happen. And it also removes the opportunity for them to have a good quality death that's well planned and with the appropriate people with them. So Judith Nelson's an intensivist, and she wrote, "When it is not possible to save a life, then I've learnt to save a death, to help a patient preserve comfort and dignity, to help a family understand the inevitability of death and how to move forward in the process of bereavement." And she wrote this article when she realised that she had more thank you letters from families of patients who died than from the ones she'd saved. So how do we reduce end-of-life care MET calls? Well, first of all, we need to identify patients who are at risk of dying, complete limitations of medical treatment early in the admission, review the goals of care throughout the admission, and perhaps offer an alternative model of support than the MET call. One of the things that we find when we're dealing with a lot of the people in the hospital is that they're very black and white about patients' prognosis. And the patient is either going to live or they're going to die. And they don't really think about patients in the context of risk of dying. And what we found from talking to people about this is that poor prognosis doesn't stop doctors treating a lot of the time. And when I was doing a lot of this stuff when I first started at the Austin, one clinician came up to me and he said, "I get what you're saying. I know it'd be good if we could diagnose dying." He said, "But if there's still 1% chance that I can save this person, then I'm going to do everything that I can." And it was at that point that I realised there's no point teaching them how to diagnose someone who's dying because it doesn't really matter to them. And what we've done is change the focus to how to diagnose someone who's at risk of dying, continue doing all the same things that you want to do, but also do, as Karen said, start planning for the rest of the alternatives. And that way you're giving both aspects of care. The surprise question has been around for a few years and has a lot of supporters. My only concern with it is that you need to be a certain level of experience to be able to get an impression whether someone's going to die in the next 12 months. And the problem that we face is that a lot of these assessments are made by junior staff. So while I think it's a great concept in principle, for the work I do at reducing unplanned deaths in hospital, it's not that useful. But there are a few tools that have been developed. And these are all from Australian researchers. So Magnolia and Ken released a paper on the Crystal tool, which is a 29-point checklist that can be done on admission or MET tool to look at people's risk of dying. And they're doing ongoing work to validate that tool prospectively. The SPIC tool did come out of Scotland. It's Supportive and Palliative Care Indicators tool. But a group at Monash did a study last year and they found that patients who met one or more criteria on the SPIC tool were more likely to die after a MET call. And then from Bowen Health, Sharon and Neil and their group looked at 626 patients at Geelong Hospital and looked at whether they had any of the diagnoses of chronic illness on the gold standards framework and found that 27% of patients met that criteria and that their mortality was significantly higher than those patients who did not have any of the criteria. And as you can see, a one-year mortality of 50%, this is a group of patients that we need to at least be planning with rather than just waiting till the wheels fall off. So how do we make people complete a limitation of medical treatment early in the admission? The Austin Health has a policy that within 48 hours they need to have a green form or a limitation form done if they're over 75 or have significant chronic illness. We need to work out what patients to choose, and so we could perhaps use some of the tools I've identified, or even using an old tool like the Charleston with a new version that only has 12 comorbidities, can predict risk of death during the admission. And the other thing that's been done a lot over the last few years is making the forms better. So taking away the concept of choosing what treatment to have or what not to have, which is the resuscitation form, but moving towards a goals of care form, which is a more patient-focused approach. And so there was a combined paper a couple of years ago from Tasmania and Victoria looking at the goals of care form that they developed. And it was based on a US model of the PULSED. And what they've done is assign patient episodes or their admission to one of 3 different categories based on the overall goals of treatment for that patient. And it was either curative, palliative, which is living with a life-threatening illness and preparing for death, but not necessarily this submission, and then terminal. And the trial they did is obviously in the full paper, but one audit they did found that NFR forms were only completed for 34% of patients, but the goals of care forms were completed in 75%, which perhaps suggests that they're a lot more reality-based and an easier concept to get your head around, rather than the checklist or the supermarket list of what treatments you are not going to offer. This is the form that we've got at the Austin, which you won't be able to read, but no, which button? Okay. Oh, there it is. Whee. So up the top, what we've done is it's a lot more about advanced care planning. So with all the work that's been done with ACP over the previous years, there's often still a disconnect between what the patients and the relatives have and what the treating team find out about. So this is a prompt that they need to find out. Look at the system, look at the medical record, ask the family, is there an advanced care plan? Then we've gone for a 4-step approach. So this is the curative. This is curative in the context of a life-limiting illness, but so getting people to be aware that it's a life-limiting illness, but still doing everything that admission. And then we've got a palliative approach, which is just a goal of symptom management, and often these patients get home. And the last one is terminal care. The back obviously is very hard to read, but it's a lot of explanation for doctors. How do you make the decision? How do you decide what the patient's goals of care are? How do you decide when they've got life-limiting illness, and how do you frame it all? So that's meant to be a resource for the doctors. We know that patients don't often have good goals of care done throughout the admission, and I did a survey a few years ago and found less than a third have well and clearly documented goals of care. And the problem is that the longer someone's in hospital, the less likely they are to have clear goals of care, which makes it very difficult if something suddenly happens. So goals of care should be clearly articulated on admission and regularly throughout that admission in consultation with the patient and carer. There is always going to be the difficulty of uncertain prognosis and outcomes. That's just a part of life. And one of the things that a lot of doctors seem very uncomfortable with is how to deal with patients and families in the face of that uncertainty. In medical school, we learn that every problem has a solution, but that doesn't translate into practice. And we've heard about the Amber Care Bundle this morning, but basically what it does is it looks at, this is your curative, in, out, one problem, one fix. This is your last few days of life, whether it's Liverpool Care Pathway or some other end-of-life care strategy, and really that's done reasonably well. The big issue is this uncertain period in the middle, and this is when you often find, they're treated for a DVT, then they're treated for pneumonia, and then they're treated for this, and then they're treated for that. And suddenly you find the patient's been in hospital for 4 or 6 weeks, and your chance of getting them home become very uncertain. And I'm sure we've all had patients who at the end of these long admissions kind of go, what was all that for? Why did we do it all? And so the Amber Care Bundle has an emphasis on sitting down with the patient and the carer at that time and deciding what the goals of care are. One of the major barriers at our hospital to good end-of-life care planning and care are the doctors, and the senior doctors in particular. And we did surveys and multiple forums to come up with that. Now, you can imagine that concept went down like a lead balloon, really. And so what we did at the Austin is we developed a project called the Clear Decisions Project, which stands for Consultant Leadership in End-of-Life Care and Advanced Care Planning and Treatment Decisions. It was a 2-year project that's ongoing, although unfunded, and we had a palliative care doctor as the project officer who worked with the senior medical staff of individual units to develop resources and develop and undertake projects in their units to fix the things they saw as the issue. And as you can see, we've worked with a range of units, and we've also done a little bit with our orthopaedic unit. We've developed hospital-wide resources for the doctors and policies, and have run multiple sessions on communication skills for both the senior medical staff and the registrars. And there are a lot of people feel that they should become mandatory. We've also held 6 hospital-wide end-of-life care forums to discuss various issues and progress this work. And we've done a survey which showed that the senior medical staff feel that it's really made a significant improvement to the way they manage end-of-life care in their units and across the hospitals. So what are the alternative options to a MET call? We did a project looking at palliative care registrar attending the MET call and assisting the team and family with decision making. And that was felt to be quite useful for both the families in particular, but also the junior medical staff. In Ballarat, they've trialled a palliative response team, where in hours the palliative care team will respond to a call, and out of hours it's a palliative care trained MET team. And that was felt to be an option for patients who are distressed or rapidly deteriorating in a way to get more help and experience to manage a dying person. And another option would be a de-escalation process. So sometimes you can't stop the MET being called, but perhaps if we develop a checklist to help teams step down from the MET call and institute good end-of-life care planning then. And lastly, I'll leave Jerry to have the final word.